Welcome to Proactive User Knowledge. In this session, we will provide an overview of our mentorship program and its benefit. Join us to discover how our program can enhance your skill and support your professional growth. So these are the things that we are considering during our mentorship plan, and this is some overview that you are going to learn in this mentorship, as well as you will learn more about some fundamental movement pattern, as well as how you can retrain the pattern of a shoulder joint. We will also discuss about the motor control training, the biotensegrity model, as well as what are the contact points that we should consider it. These are some key functional tests that we should consider it during the shoulder assessment part. There are a cervical mobility test, a functional shoulder screen, the motor coordination test, and the control mobility as well as the functional performance test. By understanding these tests, you will know about which muscles are working efficiently and which muscles works very overworking. We need to understand about the posture foundation and the spinal stabilization. I'm also going to discuss about the pelvic and the chest relationship. What is intra-abdominal pressure versus bracing part? We will also deep dive into the supine muscle coordination and the movement training. And at the top of that, the movement pattern understanding from supine to sideline to prone, and from prone to sit. So in this session, I'm just giving you the idea about the how these things will go. The requirement for improving the shoulder performance by adding this element that you can significantly enhance the performance and resilience for the shoulder joint. We need a mobility as well as the stability. We required a neuroarticular myofascial coordination as well as the kinetic chain. We have to uh, rehabilitation of a shoulder from whole kinetic chain perspective. Now let's understand about upper cross syndrome. Upper cross syndrome is a postural imbalance and that typically involves the tightness in some muscles and the weakness in others. But in day-to-day clinical settings, it becomes very garbage term like a hypertonicity as well as the stiffness. This upper cross syndrome can affect the alignment, which is related to the function. Sometimes there is a change in the torso as well as the lower limb alignment. So upper cross syndrome has a more of tendency regarding weakness and the inhibited muscles, rather to use a hypertone as well as the stiffness of a muscles. In upper cross syndrome that you can find about the interscapular pain as well as this region become flat. There is an impaired intersegmental movement also. And there is altered alignment at the craniocervical junction, the thoracolumbar junction. This may develop a pain in the upper back. Sometimes it can radiate to the interscapular region also. There are some common injuries, which is the subacromial impingement, the most common diagnosis about the shoulder joint. In common injuries, usually we see in our clinical settings about the rotator cuff related shoulder pain, the rotator cuff tendinitis, rotator cuff tear, and the shoulder joint has a many source of pain like a soft tissue, AC joint pain, and neck related shoulder pain also. All these things that we will deep dive into this mentorship plan. And pain increase with the age? What do you think? Yes, the pain increase with the age in the shoulder joint. From this literature, they conclude that the prevalence that continues to increase in physically demanding occupation. The clinician should consider the factors of occupation when managing the shoulder pain. So as the age increase, the shoulder pain may increase, but that is also related to the patient's occupation. And the subacromial pain, subacromial impingement that can lead to the rotator cuff disease also. When there is a tendon in the shoulder which are overloaded, that is due to the repetitive stress or weakness, the risk of compression increase. Due to that, the overload tendon becomes more prone to limitation. There is an inflammation and the thickening of a tendon also. This can cause them to occupy more space in the subacromial area, which increasing the risk of compression against the acromial process. As a result, the tendon becomes even more inflamed and creating the vicious cycle of pain and dysfunction. And that's why we give the label for the patient that is about the shoulder dysfunction. We must identify the kinesiopathological model, why the person develops this inflammation, whether there is a imbalance between the rotator cuff and the deltoid, or the scapular muscles is responsible for this. Once we understand about how to identify the muscle imbalance, this gives us a very good prognosis for our patient. The rotator cuff disease, which have a variety of label. The tendinopathy, partial thickness tear, and the full thickness tear. This is the partial, and this is the full thickness of rotator cuff problem. We need to understand about the biotensegrity model also. Biotensegrity, which is about the tension and compression. How the human body maintains its structure and movement through a balance of tension and compression. The forces are distributed throughout the body rather than acting on individual joints or a bone in isolation. If you look at this model, if you pull one string, the other string is also pulled towards the side of pulling direction. Let's say an example of a shoulder joint. When the person complains of pain at the anterior aspect of the shoulder joint, if you press on the anterior aspect of the shoulder joint, sometimes the person has a severe pain, but on the other side, if you release the posterior capsule, or if you release some forearm muscles that may reduce the pain on the anterior aspect of the shoulder joint. It's like a Spider-Man costume, or any costume which is covering the body. Okay, so if you pull a costume from one side, the opposite side is also pulling. So likewise, we have to understand about how the movement occurs, and this biotensegrity model helps us to explain the efficient movement, injury resilience, and the adaptability in biomechanics and rehabilitation. There are movement distribution. When this biological structure possesses a degree of resilience, which allowing them to bend, stretch, deform, and shape. The resilience in a muscle's attachment and the periarticular areas effectively distribute the stress and strain both laterally and longitudinally. So the proportion of movement that we need to understand when the person is showing the specific movement pattern with complaints of pain, we need to understand about what are the structures they have involved. So if we look from the biotensegrity model, this helps us to understand about how these tissue are behaving. And there are some different thinking in traditional as well as the current thinking process. In traditional way, some school of thought is telling when the muscle moves, superficial fascia doesn't move at all. But in current scenario, when the muscle move, the interlinks stiffen up and the fascia also. So from that point of view, perhaps the 15% of the movement occurs in a superficial fascia, and that's why the K-tape can affect the superficial fascia and the muscle itself. And the myofascial sling, these slings play a vital role in allowing the efficient, coordinated movement pattern and supporting the body in various complex tasks while maintaining the balance and the posture. And I am also going to discuss about this myofascial sling with the help of Tom Meyer and make you understand about the contralateral contact point in a supine position, as well as I'm going to also discussing about the how the person's is behaving, the person's muscles contraction in a supine position also. So if you want to join this program, you can contact me on my WhatsApp, as well as you can reach my social media. Thank you so much.